Whenever national unemployment rates climb, a distinct ripple effect hits the healthcare system. Waiting rooms at primary care clinics begin to overflow. Epidemiologists operate on a well-documented baseline assumption. Macroeconomic instability consistently predicts higher rates of both illness and death within a population. But while the statistical correlation is clear across millions of people, pinning down the exact individual-level mechanism that drives a recently laid-off worker to the doctor is surprisingly difficult. This forces a highly specific medical question. Does the stress of a collapsing economy cause actual organic physical disease, or is something else entirely responsible for the sudden spike in clinical visits? Relying on retrospective data makes this nearly impossible to answer. If we only study patients after they are already unemployed and sick in a clinic, we can't separate pre-existing conditions from new ailments. To uncover the true pathology of economic stress, we must stop looking backward at national trends and start tracking healthy individuals in real time. This is a 1985 paper by Dr. Margaret Lin and her team, examining the effects of unemployment on mental and physical health. The research team recruited a cohort of 300 healthy, employed veteran men at a Veterans Administration medical center in Miami in 1979. What makes this study uniquely powerful is its prospective design. They didn't wait for people to get sick. Researchers evaluated these men every 6 months, establishing a highly detailed, ongoing baseline of both their physical and psychological health, while everyone in the cohort was fully employed. Over the course of the study, 30 of these men involuntarily lost their jobs due to being fired, laid off, or dismissed. To measure the exact impact of that shock, the researchers matched these 30 unemployed men with 30 of their peers who kept their jobs, perfectly aligning them by age, race, and their initial health baselines. By holding identical health data on both groups right up until the moment of job loss, we can isolate unemployment as a pure, independent clinical exposure. Exactly 6 months after the treatment group lost their income, researchers gathered the follow-up data. This table shows psychological function scores from standardized clinical scales. First, there is a statistically significant spike in clinical depression among the unemployed, jumping to an adjusted mean of 20.5 compared to 16.1. We see a parallel significant spike in anxiety, climbing to 11.9. Interestingly, broader psychological metrics like alienation and locus of control showed almost no significant variance. The distress these men felt was highly specific to their immediate state of mind. To ensure these results are solid, the researchers used a statistical technique called covariance. By mathematically holding the pre-unemployment baseline scores constant, covariance neutralizes any minor pre-existing personality differences between the two groups. Because those initial variations were scrubbed from the final numbers, we can definitively say these acute spikes in anxiety and depression are the direct, unassailable result of losing a job. The psychological distress translated directly into physical strain, which becomes clear when we examine the cohort's healthcare utilization metrics. Table 3 reveals a massive discrepancy. The unemployed spent an average of 5 days sick in bed, compared to less than 1 for the employed. They made nearly 5 times as many physician visits and were prescribed twice as many medications. On paper, this reads as a catastrophic drain on medical resources. You would naturally expect these men to be suffering from severe, acute physical illnesses. But here is the central paradox of the data. Despite the massive surge in clinic visits and days spent in bed, the actual number of diagnosed organic illnesses did not differ between the two groups. The statistical difference is entirely non-significant. The complaints driving these men to the doctor were largely episodic and poorly defined: skin rashes, gastrointestinal issues, and respiratory problems. The clinical mechanism explaining this influx of patients without underlying pathology is called somatization. Somatization occurs when severe psychological distress manifests physically as genuine bodily symptoms. The body translates economic terror into a stomachache, draining healthcare resources to treat a symptom with no organic root. There is one glaring anomaly in the psychological data regarding how these workers viewed their own self-worth. Contrary to what you might expect, The average self-esteem of the unemployed men did not significantly drop. The explanation hides in the margins. Look at the massive standard deviation of 13.2 for the unemployed group self-esteem scores. Practically, this massive variance means the reaction to job loss was not uniform across the cohort. Instead of everyone feeling a little worse about themselves, the group split. It formed a bimodal distribution where some men coped exceptionally well, while others collapsed entirely. The primary mediator determining which side of that curve a man landed on was his level of social support. The data shows that strong support from family and friends directly correlated with retaining high self-esteem and experiencing vastly lower levels of perceived stress. Social support operates as a literal, measurable prophylactic buffer. It stops the cascade of anxiety before it has a chance to mutate into physical somatization. If we synthesize these variables, we can map out a predictable, step-by-step pathology of economic disease. It begins with an involuntary job loss. This triggers the abrupt loss of an individual's primary financial and social anchor. For those lacking a robust social buffer at home, this degradation rapidly turns into clinical depression and anxiety. At a critical threshold, that mental distress breaches into the physical realm through somatization. The resulting behavior is a desperate search for medical relief to treat genuine physical pain, driving a 5-fold increase in primary care visits. But the general practitioners examining these patients are often entirely unaware that the person sitting on their exam table was recently fired. Economic trauma reliably mimics organic disease, and its final systemic outcome is always the same: a flooded clinic waiting room. Health economists refer to the macroeconomic fallout of this phenomenon as the inverse care law. It's a cruel irony. Job loss creates a population requiring intensive medical care at the exact moment their ability to pay is eliminated. This places immense strain on public health infrastructure as patients defer care until their psychosomatic symptoms become completely unmanageable. The ultimate warning from the Lynn study is directed squarely at clinical practitioners dealing with sudden, nonspecific somatic complaints. Prescribing another round of medication for an episodic rash or a stomachache will fail if the root trigger is ignored. To effectively treat sudden psychosomatic morbidity, physicians must proactively screen for recent socioeconomic stressors. The only way to resolve the physical symptom is to treat the economic trauma.